In my view, there are few disorders more interesting and, frankly, more challenging in terms of their treatment than personality disorders. And the individuals who support people with personality disorders tend to be psychologists and psychiatrists with a particular focus in this area because it is a very consuming area of study. The same, by the way, is true of the neurocognitive disorders. We tend to find that the people who are experts there have focused there, and the same thing when we talk about substance and dependency. Now, personality disorders really are dysfunctional personality patterns. It says personal there, it should say personality patterns, and they occur in three major clusters. The cluster A disorders are characterized by odd or eccentric behaviors and an aversion to social relation. These are people who are quite reluctant to interact with others. And the first of these is the paranoid individual, and as the name suggests, this is a person that has a strong distrust for others and feels as though society or other people are out to take advantage of them or out to get them. They quickly explain other people's behavior toward them as intended as a way of harming or illicitly gaining from the individual. Now, the schizoid and schizotypal person are distinctive, but we're going to treat them for the sake of this particular course as being relatively similar. And what they really refer to is the individual who has eccentric and socially withdrawn patterns of behavior. This is the person who would sort of stand out often in a community as being somewhat more of an aberrant individual. And to some extent, people with these particular personality disorders are less and less obvious nowadays because, frankly, we have more people who are homeless and more visibly dealing with other mental health needs. But in many communities, 20, 30 years ago, people could have told you in a small town who were the individuals that were the local eccentrics, who were the hermits, who were the people that had something unusual going on and didn't tend to socialize with other people very much. They aren't terribly dangerous people or anything of that order, but they are people who often stay completely away from other people or at least limit their exposure. And that's what the schizoid and schizotypal people basically can be described as. Cluster B people are people who have dramatic, emotional, and erratic responses, and particularly this word emotional is really at the root of it. Perhaps the most prominent of these is the individual with borderline personality disorder, or BPD. And this is an individual who can have, and as we said earlier, the borderline refers to the idea that this person's behaviors and thoughts are on the border between neurosis, strong distortions in behavior and thought, all the way up to psychosis, where a person starts to lose context with reality, or contact, I should say, with reality. This person with borderline personality is an individual who can have a very quick and dramatic response in relationships. So that individual, for example, would not only like you when they meet you, but would probably like you extremely in the first few days that they meet you. And then for reasons which seem completely minor to most folks, they might suddenly have a dramatic change of heart about you and suddenly become completely against you. And this is the sort of person who may act out as a result of that, doing something like, for example, stalking or keying a car, or acting out acts of vandalism, making threats, that sort of thing. Or they may simply completely socially withdraw. This is a person who can be threatening one moment and seductive the next. This is an individual for whom threats of suicide or self-harm can be relatively common, and so can other forms of ultimatums or social threats, such as "I'm going to leave you" or that sort of thing. And these people can be very challenging to interact with because they can become very alienated very quickly from their therapists and from their entire group of therapeutic professionals, and including their family. They're not easy to remain in relationships with because they are so erratic. The person who's histrionic has particularly strong emotional and dramatic responses to things, again, often out of context with the event that occurred. So this is a person who would throw a glass of wine at somebody's face in a restaurant for really no reason, or stomp out on others, jump out of a car as it was driving down the street because of a disagreement. So that individual often has a stronger reaction than you might expect to a minimal stimulus. The narcissist is a person who's really focused predominantly at themselves, often to the disadvantage of others or the damage of others, and in particularly if this is a parent of a child, they tend to be focused more on themselves and sometimes are cold, neglectful, and detached from other people. They tend to be, again, very dramatic and threatening when individuals do anything that they perceive as a threat or a sign of disrespect, and they tend to be very vigilant about anything that might be seen as disrespectful. The antisocial personality disorder is the person who really and truly does not care tremendously about social values. Sometimes people refer to this individual as being sociopathic, meaning they just don't really care a great deal about what society cares about or wants, and in fact, in some cases, find it highly reinforcing to do things other than what society wants. They like to cause trouble. They like to disrupt. And so these are often folks who find it rewarding to go out and cause harm to others or to behave in a way that is socially disruptive. So when we think, for example, about riots and who might start riots, these are sometimes the people who would be out there trying to cause as much social chaos as possible. Cluster C are people who are anxious or fearful in some way. So the first of these is the dependent personality disorder, and in particular we're talking about the individual who is dependent on another in an intimate relationship. Sometimes we hear people refer to this casually as codependency, but this is a person who finds it very difficult to break away from somebody else in their life, even though that other person might be somebody that is causing them harm or threatening to them. They may be emotionally or physically abusive to this person, and yet the individual stays in the relationship. The avoidant personality disorder is the person who is profoundly shy or socially withdrawn. They're different from the schizoid and schizotypal person who simply is distrustful of society and other people. The avoidant person isn't distrustful, they just have a tremendous time getting past the hurdles of social interaction and tend to be very sequestered away. The obsessive compulsive personality is an individual who finds that they rely tremendously on structure and on orderliness in their life, but they don't meet the criteria purely of obsessive compulsive disorder. So this is a person who feels very out of sorts if their home isn't exactly in order or the routine isn't exactly in order, but the home and the routine are not aberrant in terms of their structure. So the person doesn't have a routine that is somehow strange, it's just that they are very, very strongly attached to that routine. Now, personality disorders, as we said, are not only challenging in terms of diagnosis, but also in terms of how they impact treatment, because as you can see, in each of these cases, they reflect that the individual has established patterns, often very dysfunctional patterns, of coping, and B, each of these would have a very significant impact on the ability of the person to form and sustain relationships, including relationships with people who would be their caregivers or their therapeutic professionals. And so personality disorders really need to be addressed at all stages in the support of a person. And again, this is where it's worth going off and getting more expert support or doing further research. Truly, we could have had a 24-hour course just in personality disorders and really needed to dive in even further into this particular area. One place I would like to point you is to the dialectic behavioral therapy. We spoke a little bit about that in module number 7, and this is Marshall Linehan's approach to dealing with people, particularly with borderline personality disorder, and it's worth doing further research on, especially if you know that people you're interacting with may have some of these personality disorders. Now, there's an old expression that when all you have is a hammer, everything becomes a nail. And what this means is that sometimes when people have learned a little bit, they start looking around and seeing that everything in the world fits what they've learned. We need to remember that personality disorders are significant distortions of personality, not just anomalies, not just oddities. We all have oddities to the point that we could say it's normal to be abnormal. But these people have very consistent, very predictable, but very dysfunctional patterns in their behavior. And they typically have learned them from their families. And when we look at the person's family, we'll often see an ongoing pattern throughout the generations of some of these disorders. And so we have to keep all of that in mind as we're engaging with people. Personality disorders are fairly common and probably are not as well estimated or counted as other disorders because they're not as easily recognized, nor are they as easily treated. And in many cases, clinicians are actually reluctant to try and address personality disorders because the research and the methodology is just not as clear. And these are some of the disorders that are typically not dealt with through medications. Although the person may have other symptoms of other disorders that do receive medication, typically we wouldn't give a medication purely for a personality disorder. So let's do a journal entry. It's been a while since we did one. Have you or anyone you know ever exhibited symptoms that others might have thought indicated a mental health disorder? And I'm not asking you at this point to reveal a great deal about yourself. Obviously, the journal is a public document and we want to keep people's privacy respected. But what problems might occur that can create these same symptoms but not result in an actual disorder? So let's be clear about this question. The first question is simply a yes or no question. Can you think of a time when you or somebody else that you know might have behaved in a way that if you didn't know the context might have seemed to be the symptoms of a mental illness? And the question that's more expansive, the one we want you to give a longer answer on, is the second question. What problems might occur that can create these same symptoms but not result in an actual disorder? And what we mean by problems are things that are happening in people's lives other than mental illness. And when we're finished with the journal, look at what other people had to say, and we'll wrap up by talking about problems versus disorders.